Can you see my slides?
Yes po.
Am I audible enough?
Yes, Doc.
So this will be a very short lecture and very basic on infertility. Okay. Uh, you can read it from your books, from your internet, from journals. Basically, it's the same everywhere. Medyo mas relaxed to compared with my other lectures. And of course, it's also my favorite because I'm an infertility specialist. So good morning, everyone. This morning, we're going to talk about infertility. And here are my references, Compregaine and Spiroff. So fertility, um, approximately 85% of the so-called normal couples will conceive within a year. And 95% of couples will conceive after 2 years. So when you see these figures, oh, it's easy to get pregnant, right? And we see a lot of teenage pregnancies. We see a lot of accidental pregnancies. So why talk about infertility, right? On the other extreme, infertility is the inability of a couple to conceive after 1 year of trying. That means having 12 months of unprotected regular intercourse. So if they are on contraceptives, if they are far apart from each other, they don't have regular sexual intercourse. Like we have a lot of patients who are one one of them is for example an OFW, so they don't get to see each other, or one works in the south like Visayas or Mindanao, so they don't have regular intercourse. So when you say primary, that means when a woman never got pregnant, and secondary infertility when it follows a previous pregnancy. And a lot of cases, majority of our cases belong to the secondary infertility. So infertility is not an inconvenience. It is a disease of the reproductive system that impairs the body's ability to perform the basic function, which is your reproduction. Okay? Sabi nga, go forth and multiply. Okay? However, for somebody who has infertility, it's very frustrating, heartbreaking, and as seen here, you get a lot of advices from even people you don't know, especially a lot of pressure from your families and your colleagues and even your friends, okay, who all have children. So fecundability decreases over time and with increasing age. And there is some degree of urgency required in managing the infertile couple due to the ticking biological clock, especially for women. So this graph just shows you that with age, the number of follicles decreases. So the relationship with increasing age to the number of follicles. So as you reach mid-30s, there's already a decline in your fertility. And once you have regular cycle and menopause, of course, there will be no chances anymore to have child by that woman. Okay. So this depicts of the same thing as we age. So there's increase in the miscarriage rate, and of course, decline in maximum fertility. So what are the causes of your infertility? Okay. Of course, we see them as a couple. It's not just the woman or not just the male partner, but it should be both of them because, as you can see here, male problems constitute 35% of the time, and tubal and pelvic pathology also comprises 35%, ovulatory dysfunction 15%, unexplained infertility, which means that all your laboratories, all your investigations are normal, and yet you see infertility. And unusual problems comprise 5%. So there's an overall long-term decline, not just in the US, but all over the world with regards to fertility rates. And why is this so? There's now greater interest in advanced education and careers among women. Women are more career-oriented. They marry late. There's improvements in the contraception and easier access to family planning services. Our group, we have our family planning unit in Jose B. Lingan Memorial General Hospital. We have trainees. We have trainings every year on family planning. We go to different LGUs to train the midwives, the municipal health officers on basic family planning. So there's more access now to them. And the government has all these programs for them. And we also teach the future teachers to teach family planning services. So there's easy access. And of course, delayed childbearing because maybe they're not yet financially stable. And as you can see, there's decreased in family size. Okay, so because of uh, just the present crisis now, the gas and diesel prices are really very high. Okay, so when do we need to initiate evaluation for infertility couples? If a woman is less than 35 years old, they evaluate after 1 year or 12 months. However, if the woman is 35 or above, you may initiate it earlier, even after 6 months. If a woman is more than 40, you may now, even there's more urgency. So you need to start immediately because of follicular depletion as you age. There's correlated decrease in the quantity and of course the quality of the eggs. There's increase of your eggs being abnormal or aneuploidy, or not just the eggs but even the embryo. Okay, so this is just a cartoon depiction on the meeting of the egg and your sperm. Okay, so usually when you have more complicated cases, these infertility cases are better referred to your reproductive endocrinology and infertility specialist, okay, or assisted reproductive technique specialist. Okay, again, we should evaluate sooner for the female if there is compromised reproductive function, such as there is oligomenorrhea or amenorrhea, known or suspected anatomical pathology, such as your uterus, you have myomas, tubal, there's hydrosalpinx or peritoneal disease, or even moderate or severe endometriosis. What are the risk factors for your premature ovarian failure, or your POF, or your premature ovarian insufficiency? You may have elicited from the history ovarian surgery, use of cytotoxic drugs, or radiation. Maybe the patient has history of cancer. She has autoimmune disease. There's smoking. She smokes or drinks alcohol. There's family history of early menopause. For the males, we evaluate sooner if there's history of trauma to the testicles, history of mumps or orchitis, we get a lot of these wherein they develop an inflammatory disease, especially your mumps or orchitis, and the count is very low, or they have varicocele and the like, and or impotence and other sexual dysfunction. Or the male has undergone chemotherapy or radiation as well, or from the start you suspect male infertility. So what are the requirements for a successful pregnancy? So it's not as easy as it looks. So the sperm, when there is sexual intercourse, the sperm is deposited at or near the cervix, at or near the time of ovulation, and the sperms travel to the fallopian tubes and should have the capacity to fertilize that oocyte. Okay? So marami siyang dinadaanan. So for the female, there should be an egg that is being released from the ovary, and that egg should be mature. Okay? This is a picture of the egg about to be released, okay, from the follicle. So this white thing is your ovary. This is the follicle, okay, and this is the egg. So the fallopian tubes must now capture that ovulated ova and transport sperms and embryo. So the fallopian tubes have a very vital function because that is where fertilization takes place. So a normal sperm can survive in the female reproductive tract and can fertilize an egg for around 3 to 5 days. Sometimes journals would say that they can survive up to 7 days. Okay. On the other hand, the egg or the oocyte has a shorter lifespan. It can fertilize successfully only in 12 to 24 hours after ovulation. That's why we have to catch that crucial moment when ovulation occurs. Okay? Because the oocyte will die after 12 to 24 hours after release. Okay? So that's as far as the ovary and the tubes are concerned. Now, once you have fertilization, which occurs in the fallopian tube, the uterus should be receptive enough, okay, to make that embryo implant and after implantation, support a pregnancy. So again, the uterus also plays a very important role. Okay, so you need to have all of your pelvic organs running smoothly for you to have a pregnancy. Okay, now let's go to the guiding principles for the evaluation and treatment. So it is to identify and correct specific causes of your infertility, and with proper evaluation and treatment, usually a lot of them will achieve pregnancy. And of course, we as healthcare providers, we need to provide accurate information and dispel that information that usually they hear from their relatives, from friends, from their marites, okay, from mass media and from the internet. That's why me personally, I always ask my patients after at the end of the first consult, for them to try to write their questions, and then when they are already after absorbing what I tell them, usually my first consult with my infertility patients would take around 30 minutes to an hour, and then list all their questions. And then when I see them again, they ask all their questions to me. I would like that better than them just nodding their heads and saying that they understand everything. And after that, some of my patients after that just will be asking my secretary questions and not me, or they will be asking their friends and not me. I always tell them, please ask me or other fertility doctors and not your friends. Okay. And of course, to provide emotional support during a trying time, especially what's quite heavy for us is when the couple do not get pregnant for that cycle, and the pregnancy test would show negative, or they would have their menstruation. So it's very frustrating. So you also have to be there as the guidance counselor, as a friend during that instance when they're so frustrated, especially if it's been years of having infertility. Okay, so we have a lot of roles as doctors. So how do we now evaluate an infertility couple? Again, as with my previous lectures, we need to have a complete history. Okay? So how long have they been infertile? Of course, the longer the poorer the prognosis is. What have been done already, the workups done from other doctors? Usually, they already go doctor shopping. Sometimes I'm the third doctor, sometimes I'm the fourth doctor, and I've been to a lot of different doctors and they were not happy with them. And I'm sure a lot of my patients also go to other doctors after not getting pregnant under my care. Okay? Because you cannot promise 100% fertility success for these patients, unfortunately. So even miracles take a little time. So we tell them to be patient. Maybe it's not their times, and of course, we try again. Okay. So for the fertility evaluation, again, are they taking medications? Uh, what drugs are they taking at present? Will that affect their fertility? Did they have previous surgeries? Did they have surgeries for any malignancy? History of chemotherapy, radiotherapy, history of infection, STDs, maybe the fallopian tube is no longer functional. There are a lot of adhesions in the pelvic organs. And very important, menstrual history. Is the female partner having irregular menstruation? Is there a history of an ovulation? Is there dysmenorrhea? So think endometriosis, and of course try to see what you can do about that endometriosis. So again, what is the physical activity and diet history of the patient? Are they on inflammatory foods? Did they previously use contraception or any medications for example, diabetes, for hypertension? Are they exposed to any occupational or environmental hazards? Okay, how frequent do they have sexual intercourse? Maybe they're just having sexual intercourse once a month when the husband comes from far-flung area. Is there sexual dysfunction? Is there erectile dysfunction for the husband? Uh, do they use lubricants which can kill the sperm in the process of sexual intercourse? And number of sexual partners before this marriage, or before this maybe they're living in at the present time. Are they prone to any STDs? Okay. Is there changes in hair growth, body weight, or breast discharge? So think PCOS, hyperprolactinemia, galactorrhea. Okay. So physical exam. So of course, check for vital signs. Check for the BMI. So you have to advise ideally that they need to attain an ideal body weight before conception. Excuse me. Examine thyroid, the breast, pelvic organs. Are there signs of androgen excess? We've discussed that in the previous lecture. And do your pelvic exam. So you do your speculum exam, your internal examination. Okay, so um, do your bimanual exam, if especially if you feel that there are signs that she may have a myoma or an adnexal mass. Uh, you feel for the um, nodulations. Is this patient having signs that she has endometriosis? Is there pain when you're examining her? Okay. Laboratories, you can ask for your hormonal studies, okay, your FSH, your LH, your AMH, and endocrine studies as needed. Your TSH is from your history. Does she look like she has thyroid problem? Your prolactin maybe. So you will ask for this according to what you have discovered. Okay, so we have the following tests for ovarian reserve. We test for day 2 to day 3 FSH, your follicle stimulating hormone, your AMH, and your antral follicle count. Antral follicle count is counting the number of the follicles during the days right after menstruation, because this will be your future follicles which will release your egg. Okay, this these laboratory tests can help prognosticate, okay, the response to gonadotropin stimulation. But remember, they cannot be used to predict pregnancy. But you can just say, oh, I'm sorry, your FSH is getting high already. We're nearing menopause, so we really have to hurry in getting you pregnant, okay? Or your AMH is already very low, or you have few antral follicle counts. You might need a lot more medications, gonadotropins for you to induce ovulation. So laboratories, these are just examples of your imaging tests. So we can do the ultrasound. Usually we request for a transvaginal ultrasound. Okay. And imaging studies again include your hysterosalpingogram to check the patency of your tubes. Like this has looks like hydrosalpinx. Okay, there is inflammation of the fallopian tubes. And how do we do this? We insert a catheter into the uterine cavity, and in that catheter, through that catheter, we insert your opaque dye. So the radiologist will be able to visualize this during the hysterogram. So when I do my serogram in Angeles University Foundation Medical Center, I usually have an anesthesiologist and a radiologist with me. We sedate the patient because before when we were in training, we just do it on our own. But during my private practice, I had a vasovagal reflux on my secretary. So she became cold, clammy, and I told everybody that from then on I will be having sedation already, because sometimes you cannot predict the pain threshold of the patient. Okay. So I now do my stereosalpingograms with an anesthesiologist. So what else do we do? Saline infused sonography, or your SIS. Here, it's a transvaginal ultrasound. We uh, place saline in the endometrial cavity, and we try to visualize, this is my actual patient, we try to visualize any masses in the cavity, which may prevent implantation. Okay, so the white is fluid, so this is the balloon of the Foley catheter, and this is the intrauterine mass, as you can see. So we need to remove this. It's in the uterine cavity because it will prevent implantation. Okay, so this is a better view. Hysteroscopy. So once we see, like for example, in the previous slide, we were able to identify um, an intrauterine mass, then we will proceed with our hysteroscopy because uh, plain DNC or dilatation and curettage is a blind procedure. So we want a better view, or we want direct visualization of that endometrial mass so that we will be able to um, properly remove and totally remove any endometrial mass that we see, okay, which we think will prevent any implantation that will occur, okay? So this is the view of from the hysteroscope. So this loop will it's like parang kinakayod mo, no? So it's uh, there's electricity. So we try to remove that mass. Okay, there. See the red when it has electricity. Okay. So we cauterize, okay, and we usually do it at the base, so we will be able to remove that mass entirely, okay? If you do just a plain DNC, then you won't be able to know, it's like you're blinded, you just do curate, but you don't know if you are really actually removing that mass, okay? So another thing we do if we discover from our imaging that there are, for example, there's a cyst, like in this case, we have an ovarian cyst, so we have to remove that cyst because it may prevent you from having ovulation because of that cyst, okay? So this is the laparoscopic view from the camera. So this is the fallopian tube. Okay. This one is our specimen bag. I think this is a dermoid cyst, so we do not want any spillage, so this is a plastic specimen bag. Okay. Again, this is your ovary. I think this is the uterus. So with laparoscopy, we try to place carbon dioxide air inside so that the abdominal wall would rise and we are able to insert all our instruments and manipulate inside and be able to remove either an ovarian new growth or a myoma. Okay. So semen analysis is done between day 2 to day 5 of no sexual intercourse. So for males, for example, it's been a week since their last sexual intercourse. We advise them to release first or have sexual contact and come back to the laboratory after 2 to 5 days and have the semen analysis done. Okay. So we now have the WHO criteria, which is we don't want low sperm count, poor sperm quality, malformed sperms, black sperm ducts, or obstructive azoospermia. Sometimes we get zero counts, okay, on the semen analysis. So when I discovered that, I already referred them to our partner urologist, and hoping that it is just an obstructive azoospermia, and there are sperms before that obstruction. Because if it's central, if the patient, the husband or the partner really doesn't produce sperms, then that would be a bigger problem. So again, management, lifestyle and fertility. So I'm now training in lifestyle modification. So lifestyle medicine, it's a new specialty wherein we want to prevent chronic diseases, we want to prevent infertility, we want to prevent diabetes, hypertension, chronic renal disease because they are increasing. We want to also to prevent cancer, and there is now evidences that for us to be able to prevent these diseases, including fertility, we have to modify our lifestyle by eating nutritious food, basically predominantly whole food plant-based, such as my lecture in the PCOS. Okay, so physical activity, refrain from smoking, drinking alcohol or other abusive drugs or medicines, and try to achieve a normal BMI even before conception. And limit alcohol consumption, much better if totally remove alcohol, and limit caffeine intake to less than 200 milligrams per day. So again, after hearing all this, so now you realize it's not as easy as you thought to get pregnant. Okay, so how do you manage this patient? So usually we try to induce ovulation or even try to super ovulate. Okay, ordinarily, if there are no medications, a woman would ovulate or would release an egg once every month if she releases an egg, because a lot of women do not even release an egg at all. Okay, they are anovulatory. Like for example, your PCOS, one very good example. They rarely ovulate, so a lot of them are infertile. Okay, so we can give your clomiphene citrate, and it's an oral medication, which is a selective estrogen receptor modulator, or SERM, with both estrogenic and anti-estrogenic properties. So how does it help? It competes with the endogenous estrogen 4 receptors, and the receptor depletion, estrogen receptor depletion causes misperception that the estrogen is low. That's why it reduces estrogen feedback, which triggers your FSH release, which consequently increases the number of follicles that will develop. Okay, so you try to fool that your brain to producing more follicles. Another inducing agent is your letrozole, which is an aromatase inhibitor. So it prevents aromatase-induced conversion of your androgen to estrogen, resulting in compensatory increase in FSH that stimulates ovarian follicular development. Okay? So if they are not able to get pregnant with your oral medication, such as your clomiphene citrate or your letrozole, we now give them gonadotropins or injectables. Okay, so we have different kinds. Your FSH or your human menopausal gonadotropins, your HMG, or even your recombinant FSH. Okay. So IVF is not quite the definition of body shots I was going for. Okay, because in IVF, we inject the woman daily with these medications, and we monitor by ultrasound if they have follicles that are developing. Okay, so usually we see them uh, after injections daily. We see them every few days to monitor those follicles if they are developing. So now management has rapidly evolved and more advanced now with the use of your ART or assisted reproductive techniques. I'm sure you have friends or relatives who has undergone ART already. So what's ART? It's assisted reproductive techniques. So these are the more advanced ways of helping our patients get pregnant. So we can do your intrauterine insemination. So what's intrauterine insemination? By doing IUI or AI, artificial insemination, we try to bypass the vaginal canal and the cervix. We already insert the washed sperms into the uterine cavity. Okay? So, we bypass the vagina and the cervix. So by introducing washed sperms, we already remove the dead cells, the infection, and we try to pick up the sperms which are more active, and those are the ones being placed inside. So you already remove the dead sperms, the pus, and all this other debris, and placing washed sperms inside the uterine cavity. But remember, with your IUI, you still need to have patent fallopian tubes because fertilization will still take place in the fallopian tubes. Okay. So another technique we do is IVF with embryo transfer. So the egg and the sperm are retrieved from the couple, and they are combined in a petri dish and incubated in the laboratory. And if fertilization and cleavage occurs, for embryo, it is transferred through a catheter back into the uterine cavity. Okay. So this is how we do IVF oocyte retrieval. So uh, we stimulate the ovary with your ovulation induction agents through your gonadotropins, and by uh, assisted transvaginal ultrasound. So this is the probe, and see above the probe you have a needle biopsy wherein we suck out that the fluid from each one of these follicles which we stimulated, and hopefully when they are being sucked in the test tube, all of this fluid will be examined by the embryologist. Hopefully they will find a mature egg from each of these follicles. Okay, so that's oocyte retrieval, or ovum pickup, or OPU, we call it. Okay. So this is my patient. So that's how we do it in the laboratory. So these are ultrasound probe. This is the vagina. So it's vaginal ultrasound. And we try to go to that ovary. And so this is the needle, okay, going through each of the follicles and aspirating the follicular fluid, and hoping the embryologist will find mature eggs. Okay. So this is how it's done. We have an anesthesiologist because it's quite painful. So the patient is sedated. We also have a sonologist to help us look for those follicles. Okay. So these are what we harvested that day. Okay. So these are the eggs. So this is IVF. So they're going to put that sperm together with the egg, and hopefully fertilization will take place. But now we have a newer technique, which is intracytoplasmic sperm injection. And with this, the sperm is injected directly, okay, into the cytoplasm of the oocyte. So this is the needle. So you inject the sperm inside the egg already. So this is just to hold that egg. Okay. So this is another picture. You inject already. So this is under the microscope, of course. The egg into that, the sperm into that egg. Okay. So a single sperm is injected directly into the cytoplasm of the oocyte. And uh, of course, this will increase the probability of your fertilization. So embryo transfer. Once now with all of our procedures are now done by after doing our ICSI, we then the embryologist will then observe this sperm and egg every day. Our goal is to reach blastocyst, okay, and freeze them. And after 2 to 3 months, when the couple is ready, we place back. So these are embryos. See, there are multicellular already. Using a catheter, we put that embryo back into the endometrial cavity. Okay. After preparing the endometrium for proper implantation. So this is an example of your ultrasound. Again, it's under ultrasound guided. We place that catheter inside your endometrial cavity. What is TESE, testicular sperm extraction? This is, as I mentioned earlier, sometimes we get cases of obstructive azoospermia. So when the urologist discovers that there are actual sperms before the obstruction, we try to extract the sperms. Okay? Or the urologist rather. So this is what they actually extracted from that. Wait, okay. So those are the sperms after your test. Okay. Can you see so there, those are sperms. There. Okay, so it was a successful surgery. There, those are the sperms with the tails, head and tails. So we also have this technology, cryopreservation, wherein either oocytes, ovarian tissue, sperms, or embryos are preserved by freezing. Okay, they are placed in nitrogen tanks. Before treatment of the cancer, like radiation, okay, or chemotherapy, which might kill even the normal tissue. And or you can do cryopreservation for genetic conditions that may increase the risk of premature ovarian insufficiency or menopause. Okay, so we have another technology, which is your pre-implantation genetic diagnosis. So actually our laboratory in Angeles, AccuArt just purchased a machine which can do this, because before we imagine we send our patient, our specimens to Japan, okay, via the company iGenomics. Now we were able to purchase a machine wherein we can do the diagnosis, the biopsy in our own laboratory. So it's a procedure that allows embryos to be tested for genetic disorders before you place them inside the uterus. Okay, so that if you have a result that's aneuploidy, an abnormality, you don't put that embryo anymore into the woman's womb or uterus because the chances of abnormality is high. Okay, so we pick the euploid embryos. So you biopsy the embryos. That's implantation genetic diagnosis or your PGD. So of course, the ultimate goal is to have a pregnancy. So this is an ultrasound picture, and these are twins. Okay. By the way, that's a complication of infertility workup. You can have twins. Before, as you can see in the news, they have quadruplets, quintuplets, or seven. The media hype before there were seven babies. Unfortunately, the mother cannot support all the babies, so she was asking for donations. So nowadays, we only insert a maximum of two embryos. So one or two embryos at a time to prevent multiple pregnancies. And before, they used to inject, imagine they inject poison into the embryos so to kill them. So of course, that's not allowed in our country. So now we are restricted with just putting one or two embryos. Okay. And of course, having a successful and safe delivery and of a healthy baby. And this is my patient with uh, antiphospholipid antibody syndrome or APAS. She had, I think, three recurrent pregnancy losses, and then she went to me. And actually, before this baby, she had another pregnancy loss with me. The babies were twins, even. So they lost the twin at, I think, 20 weeks or so. The guy is a medical representative who covers me. And I even told them, maybe we're not for each other. Maybe you want to transfer doctors because I failed. And then they said, no, doctor, I will stay with you. So after staying with me, they were able to have a baby. And now, after years, I have two babies already. Okay, so as I said, it's just a matter of time and patience for both the couple and the doctor. And eventually, you will have successful pregnancies, hopefully. Okay, so give it time. So thank you very much. So this is another successful pregnancy. So I delivered both of these kids. Okay. And they're grown up now. They are much bigger now. Okay. Thank you very much. Do we have any questions? Napahaba yata yung lecture ko. Any questions from the floor?
Wala po for me, Doc.
Ano po, Doc, what's the oldest age you have handled?
Ano na?
Yung oldest po na age na na-handle nyo na were able to deliver.
Yung infertility, 44. Pero I have a spontaneous pregnancy na 46. Yun. But I know of a colleague, wala pala akong video. Wait, how do you do? My colleague is 50 years old. Akala niya, 1 year older sa akin sa PGH. Ay, kilala yun ni Ma'am Cora. Ang tawag dito? Akala niya, menopause siya. So, pina-ultrasound, ayun, ano pala, pregnant siya. One batch ahead sa akin. Yun. So, ano pa siya? OB siya na, I think MFM pa, perinatologist pa yata siya. So, the batchmates were very scared, so she was really monitored, but she had a successful pregnancy. Okay? So, yan yung mga good news, mga wonderful stories, na success stories. So, give it time. Okay? Unfortunately lang, medyo mahal. So, sometimes nag-give up sila. Pag minsan may iba akong patients, hanggang oral lang yung kaya nila. Hindi kami man umaabot sa injectable or IUI lang sila when hopefully, sana, kung mag-IVF lang, magpe-pregnant sila. Yun. Any more questions?
Doc, magkano po ang cost ng IVF?
Ako kasi, it's a range. Hindi ako kasi depende sa one. Siyempre, pag the older, especially the woman, the more gamot. Yun yung mahal kasi injections you will give. So when I give the range around 400 to 800,000, it can be less or it can be more, because they are not going to give the money to me. Okay, they're going to spend it as we go along. If they don't have any eggs yet, follicles, I mean, I will increase the dosage until they will have follicles, until we reach a certain number of size for that follicle to be able to do ovum pickup. Okay, yun yung medyo madugo, yung injection. Yun yung medyo mahal. Yung paglagay, konti na lang yung paglagay mo ng embryo sa loob ng matres. Medyo hindi na yung ganong mahal. Yun. Of course, they will pay the laboratory when we try to extract or we try to transfer that embryo. Yun. Any more questions?
Doc, last na. Ilang years po ang residency sa IVF or ano po siya?
It's not pure IVF kasi. It's a reproductive endocrinology and infertility. So REI. So it's 2 years. So you have a 4-year residency in OBGYN, and then it's a fellowship of 2 years. 2 more years after residency. Yun. So residency is after internship, right? After your board exam. So kailangan pumasa muna kayo sa board exam and then apply for residency, and then OBGYN, that's 4 years as of now, and then go into fertility of another 2 years. Yun. And there are also exams and written and oral exams for you to become fellows. Yun. Ano pa? Any more? So, madami naman kayong resources sa infertility. So, hindi kayo pare-pareho naman yung sinasabi. Parang PCO lang yan. Very common kasi. So, basic knowledge lang, basic information. Kahit saan kayo tumingin sa internet or even ChatGPT, everything will be given there already. So, it's easy. Basic ang infertility. Unlike yung amenorrhea kasi medyo madugo siya. Tsaka yung AUB. Although, yung binigay ko naman sa inyo, yung sa Figo, pang coin lang naman. So, very, very easy. Any more questions? So, I'm giving the rest of the day free for you to please go through your notes, try to read kasi your exams yata is on May 7, no? So, hindi ko pa nako-complete yung mga exam questions ko. Easy lang naman yung exam questions ko. Okay? Sige. Thank you very much.
Thank you po, Doc.
Doc, mag-picture lang po ako.
Send nyo.
Yes po, Doc.
Send
Ay,
nyo.
open cam lang po. Smile po. Okay na po, Doc. Send ko na lang po. Thank you po.
Thank you, thank you. See you next year.
See you then, Doc. Bye po.
Bye.
Thank you po, Doc.